Good evening, everybody. I'm Jean-David Le Goyer, and I've been asked to speak about extrahepatic portal hypertension and concentrating on the current challenges. I first would like to thank the organizing committee and especially Dr. Lopez for this kind invitation. I do not have any conflict of interest to declare for this presentation. Extrahepatic portal hypertension is not only a rare disease, but a very rare disease. According to my experience, I would say that even if we do not have numbers in the literature, that it is something like 10 to 20 times more rare than biliary atresia, and that will give you a picture. The extrahepatic portal hypertension is, as the name tell it, extrahepatic, and it is caused by portal vein occlusion. The portal vein occlusion is usually limited to the portal vein trunk, but in different conditions, in 10 to 20% of the patient, it may extend either within the liver, and this is what usually we find in patients who had umbilical catheterism, or it can also extend outside the liver within the mesenteric or the splenic veins, 10 to 20% of the cases, as I told you. And this may have to be taken into account for the surgery, of course, but it is a minority of cases. When the portal vein is occluded, what happens, because the liver is normal, is that a cavernoma will develop. The cavernoma is a lot of collaterals that are joining the mesenteric vein to the liver and flowing towards the liver. Cavernoma is not very efficient to ensure a flow, and this causes portal hypertension. There are many types of portal cavernoma, so it's difficult to say one is different to the other. But of course, again, the surgeon will take into account the anatomy of the cavernoma to propose surgery. Etiology is mostly idiopathic, I mean, we don't know exactly what is the cause. For the patient who have a particular cause, we found more frequently portal vein thrombosis after liver transplantation or after previous umbilical catheterism in the neonatal period. There are many other causes, but each of these causes even is more rare. The symptomatology you will know. The first thing is that portal hypertension will develop usually very early in life, slowly without symptoms. And the first symptom may be the finding of splenomegaly and hypersplenism. Another way to enter the disease with symptoms is rupture of esophageal varices. And with time, because these patients have a long time to live with their portal hypertension, we see the effect of spontaneous portosystemic shunt. And you can see that in this case, when patients are growing, because they may survive 10, 20, or a normal liver life, they may develop huge spleen. There are a lot of other side effects that develop with time in this patient, like liver atrophy, some coagulopathy, which is not the cause, but the consequence of portal hypertension due to cavernoma. Portal biliopathy, which is also a very typical feature that develops with time and that we see mostly in young adults or in adults. Subclinical encephalopathy, they have it, even if they don't show it. When you search, you find it. They may also develop some more rare complications like ascites, malabsorption. Many of them have some degree of growth retardation. And very rarely, but some of them may develop also hepatopulmonary syndrome. There are two anatomical particularities that are very important in patients, especially with idiopathic cavernoma, which is the first, the liver parenchyma is normal. In most cases, the parenchyma is normal, even when the disease has been, or the condition has been evolving for very, very long. The fact that the liver is normal makes that these patients are not like a cirrhotic patient evolving towards liver failure, but they can survive, as I said, many, many years, decades, even a normal lifespan. This prolonged course of the condition explains why so many of these patients with time, when they are going to teenage or adult age, develop more and more complication. This is not always a very stable disease. It's just worsened with time. The second particularity is that very often, and especially in the idiopathic cases, which are the majority, the intrahepatic portal veins are patent. And you can see this is a patient with a cavernoma. There is no portal vein. This is the mesenteric vein and the splenic vein, a huge spleen. And you can see that in the same patient, although you cannot see anything on the angiography through the mesenteric vein, there is in the liver a normal anatomical pattern for the portal vein. In this case, these are the left portal vein and these are the right portal veins. This is frequent in idiopathic case. Around 85–90% of these patients have this type of intrahepatic portal system. What are the current management options we have for patients with extrahepatic portal hypertension? Just first, remember that the natural history seems to start very early in life, around the birth. We don't know exactly when it starts, but it seems this is a perinatal start. Then at the beginning, the cavernoma may be present without important symptoms, and patient will come to the diagnosis when they are 3 to 4 or 7, 8, or even later in life, and they have no symptom before. The first symptoms are usually related to the varices that can be found or the splenomegaly. And then the story will be complicated in time by rupture of the varices and bleeding, and very large splenomegaly problems that will occur mostly in teenagers. The current conventional management is to propose a very conservative approach and therapy when they are young, when they have no major bleeding or other problem, and mostly will consist in the various therapies, including endoscopic management or endoscopic intervention to start managing the varices and the bleedings when they start. And mostly in the conventional management, interventions are proposed when the patients are older and when they start getting complications that are not manageable medically. So the conservative management, as I said, is either wait and see until you get problems. Some people, some teams like to use beta blockers. There is no evidence, but many do, and we do. Endoscopic monitoring, endoscopic management, until the patients start developing other problems. The conventional intervention we can propose are ranging from portosystemic shunt, the old type of intervention that we rarely do now, esogastric deconnection, splenectomy, partial splenectomy, or the devascularization operation, like esophageal transection, also have been abandoned. Partial splenectomy is considered more often nowadays. And then there is a range of interventions that are proposed by the radiologist that are managing the varices or creating other shunt. I will say a word about that later. What's important to remember is that the conservative management is, of course, palliative, but also most of the interventions that have been proposed until now conventionally are palliative. Some, like the portosystemic shunt, may reduce portal hypertension, but they are palliative in operation in that they create other problems instead of curing the disease. There is no real good way of curing portal hypertension except the mesorex bypass. This is the third option. Remember this drawing with the superior mesenteric vein, the splenic vein, and the intrahepatic portal veins. And of course, what you can do if you have these both systems open is to join them. This bypass created between the mesenteric vein and this portion of the portal vein in the liver on the left is called rex recessus. This is the name of the operation. Mesorex for mesenteric to rex bypass. And you can see that this bypass is created towards and within the liver and allow the blood from the abdomen to go back into the liver, like would do a normal portal vein. So this operation is particular in that it restores portal flow to the liver, and it allows the splanchnic physiology to be restored. And that's a very, very important aspect of that operation compared to any other palliative operation, in that it allows to restore physiology. From the patient perspective, there are in fact 3 possible states, and we will have to decide during their life where we push them, where we drive them into. One of the first possible state is the well-known state of cavernoma and chronic portal hypertension, the one I've described with all the symptoms. The second state is a state that the surgeon can create or the radiologist can create, which is the portosystemic shunt. And the third state is the state of mesorex bypass, which means the portal flow is brought back into the liver. So let's try to compare these 3 conditions. The first one is the natural one. The patient has no intervention and is just growing in time. And I remember that this patient, because they have a normal liver, they can live from the birth to 20, 40, 50 years of age and longer. They have plenty of time to develop slowly but surely a lot of possible complications. Of course, not all of them will develop complication, but most and all of them, if they are not treated, if they have no intervention, will survive with portal hypertension. What are the principal symptoms? We already have seen them: the varices, the bleeding, splenomegaly, major hypersplenism, and cholangiopathy. Because patient with portal hypertension develop portosystemic shunting through neocollaterals, they are also exposed to have the portopulmonary syndrome, which are mostly the hypoxia. It is quite rare in patients with cavernoma, but it is described. Very often, they have subclinical encephalopathy. And if you search very, very well, in fact, all of them have subclinical encephalopathy. And many of them will develop with time some nodes in the liver. It's a question of time. If you wait until they get into adult age, most of them will have some benign but regeneration node, focal nodular hyperplasia, or adenomas. And we know it is not good to live with this type of node for very, very long. The second state is a state of portosystemic shunt, like we do with splenorenal shunt, for example, and the well-known Warren operation, is that this shunt take most of the blood. With time, they take most of the blood away from the liver. The operation is good. The patency rate, for example, after Warren is around 90–95%. There is a small risk of thrombosis. There is a small risk of needing treatment for stenosis. But what's important to remember is that this is a cure for portal hypertension, but it brings the patient into another state that, to make it very simple, I would compare to an abernating condition. Having a Warren shunt or a mesocaval shunt is having a pseudo-abernating condition. And we know nowadays that many pediatric teams are concentrating on treating abernating condition because this is not a normal way to grow and to be a child growing to adult age. The abernating condition particularly is well known to be associated with exactly the same problem, which are tumor in the liver, neoformation of mostly benign node, but also evolution towards malignant nodes have been described. Subclinical encephalopathy, in the case of abernating, we know that this is progressing very often to real encephalopathy and hypoxia. So these are the well-known and problem. Now, if we go to the third state, which is the mesorex bypass, remember that this is a physiological cue, and you can see that on this diagram. This diagram is showing that platelets after the mesorex bypass are normalizing. The spleen size, you cannot see here very well, but it's going back to normal. If you do the operation soon enough, when the spleen is not too big, the spleen size will reduce to normal. More important, and this is not observed after a splenorenal shunt, the coagulopathy that is present before the shunt is performed, the bypass, with mesorex, the coagulopathy tend to disappear, and also hyperammonemia is corrected. So these are very important aspects. And that's in comparison with the splenorenal shunt. You can see that very importantly, coagulopathy after splenorenal shunt is not improving, maybe worsening. And of course, hyperammonemia is slightly rising. It's not major, but it is slightly rising. The effect on platelet count and size of the spleen is more or less equal. Let's say that in terms of very simple outcome, which is portal hypertension and patency of the shunt, both shunts are equal. The difference is about physiological condition of the child after the operation. And I will take a little bit of time to go through that because it is still 30 years after we started to propose mesorex bypass. It is still not very clear for everybody what is the difference between doing proposing a splenorenal shunt and proposing a mesorex. So I will try to be more clear today by proposing you to visiting the mesorex bypass and the effect that this operation brings to the patient in terms of normalization of their life and correction of the problem caused by the cavernoma. So of course, the first thing is that mesorex shunt, and the literature show that very well. The first effect is that it corrects portal hypertension. It brings back the pressure to normal. It reduces the varices and make bleedings not occurring again. And it will reduce the spleen to a normal value if you operate in time. But there is much more. So I will present a few slides to show what have been shown in literature already for a long time. The first important effect is coagulation. Many patients, when they come with a cavernoma and portal hypertension, are found having abnormal value for a range of coagulation parameters. PT, factor 5, factor 7, protein C, protein S, and you can see that they all go down and they have been described like cause of the cavernoma. In fact, they are consequence of the cavernoma. There is like a consumption in the cavernoma. And what happens is that if you do a splenorenal shunt, these values do not correct. If you do a mesorex, 1 year and 2 years after, you see a trend, a real trend, and this is significant. You can see that all these values are significantly improved. In fact, they are back to normal, which means that these are not genetic abnormalities causing the cavernoma. They are just effect of the cavernoma, and it can be reversed by doing a mesorex shunt. Second, and more important for the pediatrician, the mesorex shunt have been shown to improve the subclinical encephalopathy that we find in this patient. And this subclinical encephalopathy is very subtle, and in fact, you can find only if you search. If you search, you find that these children have neurocognitive, not a good performance in neurocognitive test. This is corrected by the mesorex bypass. There are no improvement in this test when you do other type of shunt or if you do a TIPS, for example. So it's very important to note that the patient, after the mesorex operation, can go back to what is his normal brain function. Sorry for that. The same team from Superina have been working very much on this effect and have been showing more recently that there is an improved metabolic condition after mesorex bypass. There is also an improved body mass index after the creation of the bypass. This is what they showed recently. You can see that the prealbumin level and insulin-like growth factor 1 are slightly lower before the operation, lower than normal, and this is corrected after the operation. So generally speaking, we can say that the mesorex bypass brings the patient back to what it should be in its normal condition. It brings back the physiology to normal. And then we found in the literature also a few case reports that are showing the effect. Like, for example, this case, again, by the Superina team, where they had a patient who had problem after a splenorenal shunt. The trend was having more and more ammonemia, high level, and this patient was converted from splenorenal into a mesorex bypass. And you see that very nicely after the operation, ammonium level was normal. Another case is very similar because this patient was proposed for a mesocaval shunt for cavernoma. This is a patient from the Paris team. And this patient developed within a couple of years a big adenoma in the liver. So what they did in Paris is that they converted this patient. Hopefully he had a nice rex, so he could be converted. And they converted this patient into a mesorex shunt. And you can see that rapidly the adenoma reduced and cleared completely after a few years. And you can see that here the rex is well shown because it is now reperfused. You can see that the spleen is small. This is a very nice example of what a mesorex bypass can achieve in terms of curing the disease, curing the condition. What are currently the strategies we can follow? We did a few years ago with a group of experts a meeting in parallel to the Baveno symposium. And it was concluded that the gold standard strategy nowadays is to propose a mesorex bypass when technically feasible preemptively, which means that we should brought the operation not as a last proposal for when the patient is having major complication and no other ways to treat medically. The operation, the bypass, should be proposed much early when the child is younger, even when he's only 2 or 3 years of age and had no complication. Of course, this must be proposed very early, only if you are sure of the success, which means you select only patients who have the very favorable anatomy, and you try to do that in expert hands. So you can propose nearly at diagnosis this operation, because this will help to prevent most of the problem that the child would develop if you wait too long. The algorithm is thus diagnosis. Very soon after diagnosis, there is no reason to wait. Check for anatomy. If the anatomy is favorable, then you proceed for an early mesorex before complications appear, before also spleen is developing, and before varices are growing. Just the only problem, the only challenge at that time is the way you perform the assessment. There are ways to do it better, and to find the surgical expert who can guarantee a high success rate for the mesorex bypass. If the anatomy is not favorable for mesorex bypass, you go for conservative management, as we have been showing. What is interesting is that for the very few cases where there may be a failure of the mesorex bypass, with the mesorex bypass failing, the patient is simply brought back in his condition of extrahepatic portal hypertension and goes back to conservative management. During the conservative management, there may appear complications that are not manageable. If there are no complications, patient goes for many, many years and grow with his conservative management. If there are complications, again, you have to discuss with an expert team in order to proceed for intervention. What is recommended is that the expert team, remember that this disease is very rare. So, I mean, many conditions are very particular. There is the possibility that at some point in their disease, this patient may need a transplant. So what I recommend is that interventions are done either by or after discussing with a transplant team, with a team who is used to do intervention on the portal system, and who will agree to try to do intervention before the patient would come to a transplant. I know transplant is very, very rare, but nowadays, with all these patients growing with portal hypertension, they may come at some point to need a transplant, which will be the last resort. But what's important is that the abdomen has not been managed in a way that would contraindicate or make extremely difficult to consider a transplant. And I think that nowadays, in 2022, expert team must involve or must be transplant teams as well. Coming back to mesorex bypass, what are the limits, the challenge, and the outcome? The limits first. The very first limit, and that's important, is that the liver must be normal. There is no way and no sense to reperfuse the liver that would be cirrhotic or fibrotic. And we should not forget that although idiopathic cases have a normal liver, patent liver, veins in the liver, and they may be proposed for mesorex, a cavernoma may develop on a diseased liver. So it's not that the liver on a cavernoma, which is normal at the beginning, will deteriorate with time. It is about cavernoma and thrombose of the portal vein may develop in a patient who had a pre-existing hepatopathy. And a very common one we find, because of course, if there is a cirrhosis, you would see it. What is the trick is to detect the patient who have very mild hepatopathies, a cavernoma, and a normal liver function, because in this case, you cannot propose the mesorex. Typically, that would be what we call non-cirrhotic portal hypertension, obliterative portal venopathy, or some kind of sinusoidal fibrosis. And you can see that all these patients with this type of disease, including hepatic fibrosis, it's very rare to see a cavernoma, but it may happen. All these patients have normal liver function. So they are very puzzling case. And if you are not able to detect that and you propose a mesorex, you made a big mistake. The second is that although patients with idiopathic cavernoma like this one have very nice veins in the liver very often, it is not always the case that you find a cavernoma patient with these veins, like typically patients who had a story of umbilical catheterism at birth. This patient thrombosed the intrahepatic portal system and the rex recessus, and you see in this case, these are the veins from the left lobe of the liver. The rex should be there, and it is not visible on the portora. So this patient, because they have no rex, cannot have a mesorex operation. And the third group of patients where the mesorex cannot be proposed is the patient who have extensive thrombose of the splanchnic veins. Everything is thrombosed. These are usually patients, and they are extremely rare, but they are usually patients who have thrombophilia. So they thrombose nearly everything. They can't propose to many interventions. In fact, usually they are proposed for combined liver and intestinal transplantation. What is the main challenge for mesorex bypass currently? The main challenge is that mesorex bypass, although it has been shown that there are many advantages, still not everybody trusts it should be done. And some people are considering that we should prefer easier operation like the Warren operation, for example. These are two reviews, large reviews, and one meta-analysis performed last year, 2021, by two different groups. So they performed a systematic review of the most recent paper comparing mesorex shunt and portosystemic shunt. I will not go through all of their conclusion, but mostly they say that the results are more or less equal, that the patency and the thrombosis rate is relatively equal, but that the mesorex operation is much more complicated, it's more difficult, and the rate of complication or reoperation is slightly higher. So the second review considered that portosystemic shunt and Warren operation may be considered by people when they cannot propose mesorex operation. I found that a bit hard to trust. But what I can say is that these two reviews have a few bias. The first is that they are comparing the mesorex operation, which is a very recent operation. I mean, I started 30 years ago, but most teams have only a decade of experience. And what we found in literature at the moment is largely the sum of the many learning curve of many of these people. And mostly, the learning curve was even worse because they were using not the standard operation, but technical variants and bypass material variants. The second bias is that the outcome is compared only in terms of patency and thrombosis, and there is no taken into account of the physiological benefits and advantage and of the mesorex bypass, and comparing with the long-term collateral effect of the splenorenal shunt. And third, they forget also to consider that when you have the failure of a splenorenal shunt or the failure of a mesorex bypass, the solution to deal with the problems in the failed case are different and are more easier to deal with after failure of a mesorex than after a failure of a splenorenal. So let's see a little bit more about the bypass material. You know that in the standard original technique, we propose a mesorex bypass using the jugular vein. And you see the jugular vein is a long, very large, wide vein. This is an excellent material for the bypass because it will grow with the child, and this will ensure a very good flow and a very low risk of thrombosis. In good hands, and I take here the result of the two teams who have been started 30 years ago, which is Superina in America and myself, because I started with the shunt in 92. You can see that 95, 93, and 96% of success rate can be ensured because we use this standard technique with the jugular vein. Now, a lot of other teams have been starting mesorex bypass and immediately changing a little bit the technique, like proposing the bypass material, which is different. They use saphenous vein, homograft from cadaveric donors, cryopreserved vein, and so on. They also have been modifying the technique, preferring to do simpler operation like gastrorex, splenorex, or even other technique. It is, of course, different to use different technique and different material, because you see here on the left, a standard mesorex bypass using the jugular vein, a large tube that brings, like a portal vein, the flow in the liver. This is a patient who had a bypass, a gastrorex using the gastric vein. Gastric vein is very tortuous, it's not the equal caliber. And you would expect that with this type of shunt, you get more problems than with this one. Fortunately, a lot of the people who have been using gastrorex and other variations, with time and learning experience, are moving towards back the jugular vein and the standard drugs. This is a very recent review where you can see most of the team with the largest experience. You see 65, 20, 30 cases. You see that many of them have been using the internal jugular vein, and you can see that this is associated always with excellent results, 90% of success or even higher. What is important to note is that there are two teams who have been using two types of bypass. This is my team, and this is, sorry for that. So this is intrajugular vein, 89% survival. You can see that when other type of bypass are used, the rate of success is much lower. Even in our experience, internal jugular vein is providing 96% success rate. With other type, and they are very rare, but with other type of shunt, the rate of success is much lower. And this is the last and more recent paper, the same team. This is a Chinese team using both technique. They use a lot of alternative technique. And what is important from this paper I recommend to read is that they've been in the time using a lot of variant operation, and they were considering that this is working well, but slowly with time they turned to the classical mesorex operation. You know that even in the end of people who are very experienced, there is a difference in time. The mesorex operation is more complicated. It needs more expertise, but in their hands, expert hands, this is about 70 patients. You can see that the varicella decompression and the hypersplenism are much better corrected by the mesorex operation. And in their hands, they show that the shunt complication and thrombosis are lower than the one of variant operation. So they now, after quite a good amount of experience, consider that the mesorex, the standard mesorex, should be preferred to any other variant. Another challenge to the mesorex operation is the proposal, and you may have heard that in different teams, the proposal that the mesorex operation can be converted into a simple operation which can be done radiologically, which means interventional radiologists can restent the portal vein. So let's have a look a little bit about that. So the portal stent would be a solution. The portal stent would be exactly doing a mesorex operation by installing a channel, a stent, between the mesenteric vein and the intrahepatic portal veins. And you can see that in this case, this is the stent, this is a mesenteric vein, and this is the right portal vein in the liver. The left portal system is not visible, but in this case, this was considered a success. This is the equivalent of a mesorex bypass, it is true. But in fact, there are not many series of patients, because if you look carefully to search for that operation, I found only 2 papers. One is from the Paris team, and another one is from Twikil et al. And you can see that even by selecting the patients and trying to do this operation, the success rate for the operation is very, very low. 1 out of 10, 1 out of 5 operation. And in fact, it is quite easy to understand. In many patients with idiopathic portal vein cavernoma, you can't see the portal vein because they are very, very small. They are patent, but they are very small. So it's very difficult to find a way to recatheterize the cavernoma because the vein has disappeared completely. And the second is very difficult to target veins that are very, very small in the liver. So what we see more often in the literature is about tips in cavernoma. I would remind you first that tips are joining the vena cava and the portal vein. If you do this type of operation in a patient with cavernoma, you don't change anything because the problem is extrahepatic. And by doing this, you join the portal vein to the liver, to the cava, but you don't induce any correction of portal hypertension. If you find this paper I wrote a few years ago, this is a patient, this was a teenager. He had the tips inserted between the cava and the rex recessus. You can see here that the end of the tips is within the left portal vein. And of course, it thrombosed immediately because there was no flow. We were able to convert this patient into a mesorex and reperfuse the liver, even when with the stent in the rex. That was not an easy operation, but I would say that just doing a tips in this patient has no sense. Now, what you will find and what is pushed by a lot of people nowadays is modifying the tips and putting a tips or a few stents in order to reach varices or the mesenteric vein. This is a double stent in this patient. You can see that the portal vein in the liver was open, and instead of doing a mesorex bypass, this patient was proposed for a double stent going from the mesenteric vein to the cava, like that. This is a portal systemic shunt. It is not a portal shunt. It's not a mesorex bypass. It is a long stent going all the way through. And if you compare with the mesorex, you can see that in this case, the bypass is from mesenteric vein to the liver, and you see the nice liver and all the vein reperfused. There is no portal systemic shunt. In this case, what is the problem is that this child will live with a portal systemic shunt, and the next operation for this child may be the need for a transplant. At that time, the transplant guy will be really in trouble because he will find a long stent going outside of the liver through the head of the pancreas and reaching the mesenteric vein. That will be a major problem for doing a transplant in this child, which means that doing this type of operation will gain you a success for a few years and may just make the life of this patient more complicated later. Conclusion. The gold standard strategy, as it has been concluded at the Baveno meeting, the gold standard strategy in technically favorable case is to perform a mesorex bypass with the jugular vein, because this jugular vein will grow with the child and will ensure a high success rate. And this can be done very early in life in order to prevent the side effect of the portal hypertension. Of course, not every patient can have a mesorex bypass. Those who can, operate them early. And those who can't, okay, what is the strategy? Conservative management and liaise with an expert team when the patients start having more problem. Just don't try to do some operation, partial splenectomy, embolization, and then when everything you do palliatively, because these are all palliative operations, when the patient has been operated 2 or 3 times, either by the radiologist or by another surgeon, then send to an expert team. This expert team will not be able to work correctly if he's not having control of what has been done before. If there is any operation that may postpone for quite a long time without disturbing too much even the transplant in the future, then prefer the splenorenal distal shunt, the Warren shunt. Why? This distal shunt takes the vein, the splenic vein, into the renal vein. And this decompresses very nicely the spleen and the stomach. And you can see that in this case, the mesentery vein continues flowing into the liver through the cavernoma, which means that the operation divides the abdomen into 2 areas. I know that the 2 areas will connect with time, but it means that the concept is that this operation divides the abdomen into a negative area, negative pressure, or it means normal portal pressure, decompressing the gastrosplenic area. This has action on the varices and the risk of bleeding, the splenomegaly and the hypersplenism. And the shunt is very effective for that. But also very importantly, it allows to have some portal pressure into the mesenteric vein, feeding the cavernoma and maintaining a little bit of hepatopetal flow, which is good for the liver and prevents some of the problems. Doesn't prevent all problems, but what's important is that it will preserve the superior mesenteric vein for future intervention. And I think about the liver transplant operation, and the liver transplant guy who may have this patient when he will be an adult may thank you for that. Thank you very much.